I'm really pleased to introduce Dr. Sebode. He is a consultant at the Department of Internal Medicine at the University Center of Hamburg-Eppendorf in Germany. And since 2019, he's been a lead of the European Reference Network, the Rare Liver Working Group on autoimmune hepatitis as well. And one of the important pieces to highlight, he is our first overseas speaker for the AIHA, and this has been really important as we firmly believe that collaboration across continents will be really important to inform us better with this disease, but also to support the patients there as well. So Dr. Sebode, thank you for presenting today and joining us.
Okay, thank you very much for the kind invitation. I was asked, and I would also like to thank the organizers for inviting me. And I was asked to have a talk on adequate control of inflammation in autoimmune hepatitis, and whether ALT and IgG are sufficient to reflect whether AIH inflammation is under control. Next slide, please. So actually, I do not have any conflict of interest for this talk. And I will just present you just overview of my talk. So first, as Craig told you, I'm from Europe, I'm from Hamburg, and I'm the deputy lead of the European Reference Network on Hepatological Diseases, short ERN Rare Liver. And when I was invited for this talk, this was the first time that I got in contact with the AIH Association, and I had a look at your website, and I realized that many of the things that you do is probably more or less also something that we do, because this organization is also very patient orientated. And as you said, Craig, I think these collaborations between the United States and Europe are very important, and we can learn a lot from each other. So I will give you just a very, very short just introduction of this network, just to get an impression, so you can only get an impression of what we do here in Europe. But then I will come back to the main topic of my talk, which are the treatment goals of AIH. And because in the title, there's included this word of adequate. So what is actually adequate? I think this word also includes that there can be different perspective. What is actually adequate? So we'll have a look at the doctor's perspective of AIH treatment goals, but also on the patient's perspective. Next slide, please. So this European Reference Network on hepatological diseases, this is a political initiative. The European Union decided that there's a lack of care for patients with all rare liver diseases, and that is why they founded this European Reference Networks for rare diseases. Next slide. And you can see that these networks are covering several rare diseases of different organs, rare eye diseases, rare skin diseases, but of course also rare liver diseases. And next slide. The mission of these networks is clear: to improve the care of patients throughout Europe. And next slide. Here you can see the structure of this European network on liver diseases, and we are covering all rare liver diseases. Of course, autoimmune liver diseases are very important, and there's also a special disease working group on autoimmune hepatitis. We work closely with the European associations for the liver diseases, but we, as I said, we are also very patient orientated. So we include patient representatives from patients' organizations that give us input on which problems need to be addressed for these rare diseases. Next slide. And as you can see, a lot of centers are taking part in this network, and we are covering more or less all of Europe. Next. A very interesting tool of these rare liver diseases is a web-based tool called CPMS, Clinical Patient Management System. So this is a consultation tool for clinicians when you are seeking advice for maybe difficult to treat AIH patients. So you can upload this case, you can include MRI images, and you can ask a European expert what he thinks about this case and what the next steps could be. Next slide. We also have a registry, and this is a prospective registry, meaning that only patients with new diagnosis will be included. And at the beginning, when we started this initiative, we focused on the autoimmune liver diseases. And as you can see on the next slide, the numbers of patients included in these networks are still growing. Next slide. But we also have the task from the European Union to improve the education of patients. And I think you are doing a really good job when I had a look at your webpage. And I think we are using more or less the same tools. We also have webinars and also patient leaflets to improve the understanding of our patients of these rare diseases. Next slide. And we also have some scientific work. So this was a survey which was mainly driven and distributed by our patient representatives. So we reached out and wanted to know what the clinical course of patients with COVID and autoimmune liver disease is. And we reached about 1,000 participants throughout Europe. So this gave us a very nice broad overview on the situation in Europe. Next slide. So actually, this was a very short introduction of this network that we do here in Europe, and yeah, just to give you a short impression. So, but let's come back to the main topic of this talk about the treatment goals of AIH. Next slide. And the topic is, or the question is, whether ALT and IgG are good markers that represent the situation in the liver, and if autoimmune hepatitis is really under control, then these lab values are in normal range. Next slide. So actually, the scenario that we are talking about here is that the diagnosis of AIH has been made, treatment was started, and the doctors would like to know whether treatment is successful, which means whether AIH is inactive. Of course, you know that we cannot cure AIH, so we cannot give a treatment so AIH disappears. We can only control it, and we can only control the immune system, the immune cells, to attack the liver. And this scenario is also called, next slide, is also called surveillance. Next slide, please. And why is it so important that we control the inflammation of autoimmune hepatitis? Because inflammation is the trigger that liver damage will increase. And the first stop of liver damage is called liver fibrosis. And the end stage of liver damage is called liver cirrhosis. And if inflammation is ongoing, this liver damage will progress. And if you have liver cirrhosis, you can have other very serious problems that result from this liver cirrhosis. Next slide. So it's very important that we, with our immunosuppression, we control inflammation. Next slide. And even then, it is possible that if liver damage has developed and we do a very good job and control inflammation by our treatment, then it's also possible that liver damage will resolve. This is very true for liver fibrosis, but there are also some reports published that even the end stage of liver cirrhosis could be resolved and liver damage will go away. So that is why very important to control liver inflammation. There are different tests how we can measure whether inflammation is under control. Of course, the transaminases ALT and AST and IgG are very good blood tests that we have. But in some situations, we need other tools. So we have liver biopsy in the setting, not for the setting of the diagnosis, but to control whether inflammation is under control. We have elastography, which measures the stiffness of the liver. And we have established techniques such as MRI, but new sequences that will tell us whether the liver is inflamed or not. And I will tell you in the next slides what the advantages and disadvantages of each of these tests are. So transaminases, AST and ALT are very easy to determine. Every doctor or GP can test for these markers. And the good thing about these markers is that they reflect more or less the situation of the whole liver. If you compare these blood tests with a biopsy, which is actually a very tiny part of a very large organ, you could have the problem that this tiny liver biopsy does not reflect the situation in the total liver, because we know that these inflammatory liver disease and AIH can be spotty, meaning that you have in some areas of the liver more inflammation, in other areas of the liver less inflammation. But the liver enzymes, they will reflect the total situation. Unfortunately, these liver enzymes are not very specific. So in the situation where you could have AIH and fatty liver disease, if you have risk factors for fatty liver disease, you cannot really be sure if liver enzymes are increased, whether they reflect the activity of AIH or whether they are a result of the fatty liver disease. So they are not disease specific. Next slide, please. And just to remind you, and this is still the standard, the main treatment goal for AIH is that transaminases, AST and ALT and IgG normalize after, let's say, about 6 months after starting treatment. Next slide. So what about liver biopsy? The advantage is that liver biopsy, and if you have a look at this tiny piece of liver under the microscope, that you can really detect also very little amount of inflammation. So you get a lot of details out of it. And not only with regards to inflammation, but also with regards to liver damage. You can quantify exactly how damaged the liver is. Or you can detect whether there's fat inside the liver and diagnose additional liver diseases next to autoimmune hepatitis. The problem is, of course, you know, that it is painful, it has some risk factors, it is invasive, there's the risk of bleeding. And as I said, there's this phenomenon called sample error that, as I said, you have a very small piece of a large organ, and the small piece does not really always have to reflect the situation of the whole liver. Next slide. Actually, as you know, you can perform liver biopsy in different ways. The classical one is that you can do it percutaneously. A specialty of our department is that we do it laparoscopically. So here in the front, you can see the orange belly of the patient. So the orange color is for disinfection. On the left side, behind these green sheets, you have the head of the patient, and on the right side, you have the feet. And next to the belly button, we enter a needle and inflate gas into the abdomen, and then we enter the abdomen with a camera and can really have a nice look on the surface of the liver and even see how our needle enters the liver, and we can also see how severe is potential bleeding after liver biopsy, and we can also treat this bleeding by entering a catheter and coagulate this bleeding. Unfortunately, probably the video was not uploaded because it was too large, so I cannot really show you a live video from this laparoscopically, but I think I have the picture in the next slide. And this is, a picture on the very damaged, on a cirrhotic liver. So you can see all this, all those nodules, and so you can even by just one look be sure that this is definitely liver cirrhosis. You don't even need the histological analysis for this. Next slide, please. And this is the result. So when we have a look under the microscope, this is more or less how a normal liver looks like. And on the next slide, you see what we are interested in. Next slide. So we see these bluish cells, and these bluish cells are the immune cells that attack the liver. And you can see how large the area of the liver is covered by these blue cells, and you can have a feeling how severe the inflammation of the liver is. Next slide. But you can also see the liver damage under microscope. Here you can see this greenish fibers, these green streaks throughout through the liver. So these are the scars that make this nodular appearance of a cirrhotic liver. Next slide. And here's one of these cases, as I said, when you have two liver diseases in one liver. So here we have performed a liver biopsy on the top of the page of the right liver, and you can see this white areas. This is fat, so this patient had fatty liver diseases, but we also performed with our laparoscopically guided liver biopsy, a liver biopsy from the left liver lobe. You can also see this white areas in the left lobe, but you can see this bluish cells again. So only of the biopsy of the left liver lobe, you can really diagnose AIH. So this patient has fatty liver disease and AIH. We put her on lifestyle interventions and an immunosuppressive treatment, and she performed pretty well after this. Yeah, next slide. So the next tool is elastography. You know that there are different machines on the market. There was also a question in the chat. So yeah, FibroScan, this is one form of elastography, but there are also other machines on the market. And this is more or less a technique that is similar to ultrasound, but it really it measures the stiffness of the liver and really gives you a value that you can compare with future measurements. So it is not, you can, with a classical ultrasound, you just have an impression, but how the liver damage could be. But actually, you have this machine gives you a clear value that you can really compare. So the advantage is that it's non-invasive. It is definitely a good surveillance tool, and we can check whether liver damage will progress over time. The problem is that it is pretty expensive and only available in larger liver centers. So that's the situation here in Europe. And actually, one problem is that if there's very strong inflammation in the liver, this could also lead to increased values of elastography. So this machine cannot really differentiate it between very strong inflammation or damage. Next slide. And this is how it looks like. You have this probe, you put it over the area of the liver, and then you can measure the stiffness. Next slide. And this is an old technique, but a new approach that you use classical MRI to quantify liver inflammation. So the advantage is it's non-invasive. These MRI machines are available more or less everywhere. You can have a look at the total liver, and you can also screen for other organs. So maybe whether the spleen is enlarged, which could also be a hint for severe liver damage. But this technique to measure inflammation by MRI is not standardized. There's still studies who address this new approach. And it's still not clear whether it can really detect very little inflammation in the liver. And on the next slide, you see one of these pictures. And as you can see, there are areas of the liver which are more inflamed. These are the red areas, but there are also areas of the liver which are not that inflamed, so the green areas. And as I said, autoimmune hepatitis can be spotty. Next slide, please. So these were all aspects from the doctor's perspective, how we can measure whether our treatment is successful, but of course there's also the patient perspective, whether treatment goes well. So on the next slide, you will see, next slide, that many aspects from the patient side will also impact on whether treatment is successful or not. Just to give you an example, in most AIH patients, we can control liver inflammation pretty well, but still, even with normalized IgG, with normalized transaminases, with a fine liver biopsies, patients still can have symptoms that we cannot address very well, such as fatigue. We do not have a real good treatment for fatigue, and patients can have fatigue even in the situation when liver inflammation is perfectly controlled, measured by lab values, for example. And of course, there are side effects of immunosuppressive treatment. So you can use high doses of steroids, and you can control liver inflammation pretty good by it. But the patient will definitely suffer from this treatment, because steroids, they make a lot of side effects, and all these aspects will impact on the health-related quality of life of our patients. Next slide. And just to give you an example, but I think most of you probably experience one of these the side effects of steroids. You have weight gain, you have impact on your psyche, you can have depression. So the side effects are quite can impact quite heavily on our patients. Next slide. And this is just a final slide how complex or how many factors will actually impact on your health related quality of life. So we have aspects from the disease, of course, so the symptoms that the disease will evoke, but you also have factors that will that derive from your doctor, whether he's able to build up trust and will guide you through this treatment. But of course, there are also some aspects that are that derive from the patient, and which are very individual, because every patient is different and has a individual situation with regard to a social background, etc. Next slide. So I would like to summarize actually what is an adequate control of inflammation in AIA. Still, the standard is still true. So we would like to reach normalization of transaminases and IgG. But in some situations, we need additional tools. Sometimes we need liver biopsy to be sure whether inflammation is well controlled. We need surveillance tools such as elastography to be sure that liver damage do not increase over time. But there are also some new techniques that are started, and we will see whether our patients will benefit from them. Next slide. And yeah, in the end, adequate control of AIH activity is reached when both the doctor and the patient is happy. So thank you very much, and I'm happy to take some questions.
Hey, thank you, Dr. Sebode. I appreciate that, and an excellent talk. We have some questions coming up, and I think we'll just kind of lead off and maybe walk through these. We know it's important for normalization of AST and ALT, and there's a question about how important the IgG level is as well with this. Maybe I could clinically frame this as well. For me, if I have a patient with normal ALT and AST, but their elevated IgG is still a blemish on their clinical report, what's your approach? How important is this? How do you frame it for the patient? And is this worthwhile pursuing?
Actually, this is a very interesting question. And I think 2 weeks ago, there was the European Congress for the study of the liver, the so-called ILC. It was in London. And actually, I saw 2 scientific posters addressing this topic. And this is also my personal experience, that probably if in the situation when transaminases are pretty low and only IgG is increased, probably this will not impact on the outcome of patients. Of course, the current recommendations are that transaminases and IgG should be normalized, but actually this has to be studied. And in a patient where when we see these patients who have isolated increased IgG levels, and I would be fine with it. I would monitor this patient with elastography, and if liver stiffness does not increase over time, I would leave it as it is and would even not perform a liver biopsy to check how severe the inflammation is. On the other hand, if you have a patient with isolated IgG and you see that liver stiffness increases over time, then I really would do a liver biopsy to check whether the inflammation is really under control and whether I should intensify immunosuppressive treatment.
Yeah, thank you. Along those same lines, another question from the chat box is the question about fatty liver disease and how this can also be interpreted or cause inflammation that could be confusing when you're managing an AIH patient. It may be different in Europe as in North America. We have a high prevalence of NASH. I know we see more in Europe as well now. What is your approach, and how do you move that patient through, and is a biopsy always necessary?
Actually, we would try, if we suspect additional fatty liver disease. Actually, we would try to, of course, motivate the patient to lose some weight, to take part in some lifestyle interventions. But actually, if I have the feeling that it depends, like if the liver enzymes are increased, whether this patient has increased liver stiffness, I think the gold standard is still to perform liver biopsy. But this is also a topic that is on the research again now, because there are no clear recommendations what kind of inflammation is just due to fatty liver disease and what kind of inflammation is only due to AIH. And I think this is an important topic that has to be addressed to really define the histological criteria for these situation if you have AIH and fatty liver disease.
Yeah. And I think just for our members as well, at least in a few publications, looking at coexisting fatty liver and AIH as well in terms of a negative impact on outcomes as well, and actually even challenging to control potentially too. So there are implications, but much like Dr. Sebode says, this is a really important piece of research and where we're looking at. Just the very last minute before we shift over to the next segment, there's a question about blood tests being in normal range, but symptoms. And I think, Dr. Sebode, you talked about patients having extrahepatic symptoms despite normal liver tests and normal inflammation. I know this is a very important piece for our members as well. But the question maybe to go above and beyond that is there a deep remission that you target clinically? Are our patients and clinicians, should we be seeking for lower ALT and AST and IgG levels as a marker of better control and better outcomes?
Yeah, I think so. Even, like if you have within the normal range of AST and ALT, we also published this from our group from Hamburg. So if you have liver enzymes that are very low within the normal range, this is also something that what you are referring to as deep remission, because what we saw is that for the setting that you would try to stop immunosuppressive treatment, like you can do and discuss this with patients after some years of treatment, only those patients who had very, very low levels of transaminases and IgG, they did pretty good in that AIH was not coming back. So these patients did not have a relapse. So I agree that probably, like the lower the liver enzymes and the lower IgG levels, but especially true for transaminases, the lower the transaminases, the better.
Thank you, Dr. Sebode. It was amazing to have you here today. As Dr. Limert mentioned, our first international presenter, and I just think that speaks to the growth of our organization. And we really appreciate you being here and for your excellent presentation. So thank you again.
Thank you very much. This is very fun. Thank you.